Hello, I'm Caitlin Roman, a health educator. Thank you to the Bill and Melinda Gates Foundation for allowing me to present this information on the issue of rising adolescent suicide rates and what can be done to help address this issue. Suicide among young women have nearly doubled in the past decade. Adolescents, especially girls ages 10 to 18 years old, are the group that is impacted most. However, girls 10 to 14 years old have experienced the largest percent increase in suicide in most recent years. According to the CDC, the suicide rate increased by 1% every year from 2000 to 2006, then doubled to 2% every year from 2006 to 2016. The issue of increased suicide rates affects all parts of the United States. The fact that we now have such a profound, steady increase in the accomplished suicide rate among women is very disturbing. There are several factors that researchers have noted that contribute to the higher suicide rates in recent years. These factors include girls reaching puberty at an earlier age, anxiety, depression, pressure at school and work, substance abuse, lack of emotional support, or economic instability. Researchers have found that girls who reach puberty at an earlier age show higher levels of psychological disorders, especially depression, than either boys or their female peers who have that mature at a later age and are more likely to attempt suicide. Using the social ecological model, we can better understand suicide and the effect of potential prevention strategies. This model considers the complex interplay between individual, interpersonal, organizational, community, and policy levels. It allows people to understand the range of factors that put people at risk for suicide or protect them from suicidal thoughts or attempts. This model illustrates how factors at one level influence factors at another level. At the individual level, a promoting factor is having coping and problem-solving skills and knowing resources that are available during suicidal thoughts. It is also important to have healthy and positive attitudes. A hindering factor is substance dependence on drugs and or alcohol that can intensify feelings of depression or sadness, leading to increased suicide. At the interpersonal level, a promoting factor is having supportive networks that offer connectedness to individuals, family, community, and health providers, which help self-esteem and lowers the risk of suicide. The hindering factor is having a family history of mental illness and or suicide, which can increase the chances of teens being suicidal. The organizational level promoting factor is healthcare coalitions are sources of continued care after psychiatric hospitalization. The hindering factor is there are barriers to healthcare, such as a lack of access providers or medications, and which can increase the risk of adolescent suicide since the help needed is not available. On the community level, the promoting factor is public awareness and educational campaigns, which can lower the risk of suicide. Suicide hotlines are a safe place for teens to talk openly. A community level hindering factor is the media and social media can negatively impact adolescents and teens and can be a negative risk factor. There is a negative stigma on suicide and mental illness, which hinders help and health related to suicide. A promoting factor for the policy level is enacting nationwide mandatory mental health screenings and curriculum in schools that includes the topic of suicide to improve the education and knowledge of suicide resources available. A hindering factor is there is no law requiring schools to conduct mental health screenings for all students. There are three evidence-based interventions that I believe address the issue of suicide in adolescents. First is the SOS Signs of Suicide Prevention Program, which is a universal school-based depression awareness and prevention program designed for middle school ages 11 to 13 and high schoolers ages 13 to 17 students. The goals are to decrease suicide and suicide attempts by increasing student knowledge and adaptive attitudes about depression, encourage personal help seeking and or help seeking on behalf of a friend, reduce the stigma of mental illness and acknowledge the importance of seeking help or treatment, engage parents and school staff as partners in prevention through gatekeeper education, and lastly, encourage schools to develop community-based partnerships to support student mental health. The second intervention is the Zero Suicide Model, which is a comprehensive approach to suicide care which aims to reduce the risk of suicide for all individuals seen in the healthcare system. Zero suicide represents a commitment to patient safety and the most fundamental responsibility of healthcare, and to the safety and support of clinical staff who treat and support suicidal patients. Zero Suicide is embedded in the National Strategy for Suicide Prevention. Zero Suicide is founded on the principle that death by suicide is preventable. It offers an integrated system-wide strategy for suicide prevention by using specific strategies and tools. The Zero Suicide model applies the practice of identify, engage, treat, and transition to populations to increase safety, teach coping strategies, and to improve ongoing contact and monitoring of high-risk individuals during high-risk times. The third intervention is Safe Talk, which is a suicide alertness training that teaches participants to recognize and engage persons who may be having thoughts of suicide and connect them with community resources trained in suicide prevention. SAFE stands for Suicide Alertness for Everyone, and TALK represents Tell, Ask, Listen, and Keep Safe. This evidence-based practice will be adapted into communities by training Safe Talk trainers to help remove some of the barriers that come with talking about suicide. It is important that the individuals of communities are comfortable in engaging with teens and talking about the issue, spending time to listen to them. The SOS program will be evaluated by having 100% of students screened for the risk of depression and other mental illnesses. Also, after staff implement the SOS program of suicide education screening program, the goal is under 15% of students identified in the screening will need follow-up. The Zero Suicide model will be evaluated by having an increased rate of screenings for suicide, and there will be a reduction in suicide attempts and reattempts. Safe Talk evaluation will be that participants will have acquired skills to identify someone at risk of suicide, and participants' knowledge of suicide risk has increased and their attitudes towards suicidal people has changed. The overall long-term evaluation for all three interventions is that there is a decreased incidence of youth suicide. While the three interventions I just discussed are all evidence-based, there are potential barriers or challenges that may occur when trying to implement these interventions. Barriers to successful implementation of the intervention include a basic barrier, which is a lack of recognition of the problem or risk, either by the adolescent or teen, their family, or those that interact with them on a regular basis. This leads to low participation in suicide programs. Engaging external stakeholders into interventions may be challenging due to competing demands on their time, and in some cases, differing perspectives on the importance of suicide prevention. Funding limitations may cause difficulties in the ability to deliver the programs and/or services needed. And lastly, geographic location. Rural areas and distance can create several challenges. The geographic spread of some interventions mean that staff needs to travel large distances to the program. Attracting staff to rural or remote areas is difficult, and attracting workers with specific skills in mental health and/or suicide may be more difficult. Furthermore, living in rural or remote areas is a risk factor for suicide in its own for several reasons that include the potential for social isolation and limited access to services, which create additional challenges in terms of engaging the target population. Solutions to overcome these challenges and barriers are align suicide prevention efforts with other existing coalitions and youth services agencies working in the community if funding and resources are limited, and mobile and internet outreach services are a solution for those living in rural or remote areas that have difficulty reaching services. This is a logic model of all three evidence-based interventions. A logic model is a visual tool to communicate the logic or rationale behind building an effective intervention or program. The parts of a logic model are inputs, activities, outputs, outcomes, and lastly, impact. All three evidence-based interventions have a common goal of making suicide preventable and decreasing suicide incidents among teen girls. Increasing suicide awareness and making suicide resources more available in communities will help decrease the risk of potential suicides and reduce the stigma of mental illness and acknowledge the importance of seeking help or treatment. I would like to thank the Bill and Melinda Gates Foundation for listening to my presentation on the interventions and that may help in reducing the rates of suicide among adolescent girls.